So, shall we start? So, today's topic is, as you see, thalassemia and other hemoglobinopathies. Correct? Is there anyone who has any idea about thalassemia? Anyone who has any idea of thalassemia? Anyone of your family members has been affected by this disease? No one. Quite strange. So, it's an inherited disorder of blood. It deals with the changes in hemoglobin. শরীর খারাপ, পেট খারাপ, কি হয়েছে? মুখটাম করিস কেন? বস। So, it's a disorder related to hemoglobin. Correct? We know the hemoglobin, the function of hemoglobin is to transport oxygen. So, in case of any damage or any abnormality in the hemoglobin function, there will be disturbed transport of oxygen. So, that will lead a condition where the proper growth will not be formed. Moreover, if the blood fails to do its function, then we need to replace the hemoglobin. And how do we replace hemoglobin? By blood transfusion. So, when a person gets repeatedly blood transfusion, then he also get chance of getting risk of getting infection and other disorders also increases. Okay, just go through. Today's topic is very informative and very, very important. You will get at least one short question definitely from this. একটা short question পাকা। ঠিক আছে? So go through it and ask me any question, any doubt, any point, any line you don't understand, you need me to explain, just tell me. So what you need to remember, it is a genetic defect which could be either due to mutation or deletion, results in reduced rate of synthesis or no synthesis at all of one or more globin chains. One or more globin chains. How many globin chains are there? 4 globin chains of two types, alpha and beta. That is for HbA1. For HbA2, 2 alpha and 2 delta. So these can cause formation of abnormal hemoglobin molecules, thus causing anemia and characteristics presenting the symptoms of thalassemias. Epidemiology. Okay, see how alarming it is. Out of 10,000 babies born per year, 80 to 90% die. Okay, and this is not acquired, this is genetic. So, how could we stop it or reduce the occurrence? By genetic counseling before marriage. Before marriage. And this is, well, this is my city, not yours. So this is my city, this is a condition. Okay. So these diseases actually more prevalent in Africa and sub-Mediterranean area and Southeast Asia. These regions more prevalent. Now, what is it actually? As you know, the hemoglobin is formed by heme and globins. The heme is formed by porphyrin ring which contain iron, and globins are of two types: alpha, which reside on chromosome 16, and beta, which reside on chromosome 11. These you have to remember. You have to remember for the rest of your life. Chromosome 16 alpha, chromosome 11 beta. So the beta chain genes are located on chromosome 11, alpha on chromosome 16. What else the beta has? The same chromosome will also have epsilon and gamma genes. The 16 chromosome will have, in addition to alpha, this is, what is this? Huh? Well, the one who is good in physics, he can answer. Zeta. Okay. So these are the other chains of hemoglobin. If you don't listen carefully, you will not be able to understand when you go through it afterwards. Please be careful. Zeta, alpha 1 and alpha 2, but there is no beta 1 and beta 2. That means there are two copies of alpha gene, two copies of the gene producing alpha chain, but there is only one copy of gene producing beta chain, one copy of gene producing delta, two copies of gene producing gamma, but one of the gamma is not functional properly, and one copy of gene is epsilon. Correct? But only in case of alpha there is two. So if one gene is affected, other gene will function normally. There is a possibility that you will have less severity in case of alpha thalassemia. But in case of beta thalassemia, the severity will be always high because you have only one copy of beta chain producing gene. Now, types of thalassemia. Write it down. If you go through any medicine book, it will be very long. It's a big chapter. So what are different types? First, the major types: alpha thalassemia, beta thalassemia. Next comes delta. Next comes this mixture of chains. Next comes delta beta thalassemia, a rare type similar to beta thalassemia. Delta beta means which chromosome is affected? Chromosome 11. Delta beta means chromosome 11. See, in all cases, only one chromosome will be affected, either of the 11 or 16. Major and minor. Homozygous of beta thalassemia. Can anyone tell me what do you mean by homozygous of beta thalassemia? Yes? বল দাঁড়িয়ে বল, শুনতে পাচ্ছি না দাঁড়িয়ে। সিমিলার ফর্ম, আর একটু এলাবোরেট করো। On the Ovimunno. Anyone else? we have two copies of every gene located on two sister chromatid. Located on two sister chromatid. Suppose this is chromosome 11. We have the beta gene like this. Okay? Homozygous means these two, both are affected. Heterozygous means only, okay, but it still counts for one copy. If it is like alpha, then the picture will be like this. Clear? Now, alpha thalassemia. Alpha thalassemia means no alpha gene or problem with alpha gene. Correct? So we have four copies. So we have how many types? It could be like this. Correct? It could be like this. It could be like this. It could be like this. It could be like, correct? So all possible combinations might show in case of alpha thalassemia. Okay, there are different types of alpha thalassemia. Now, major and minor, this term is mostly phenotypic. This term is mostly phenotypic. Depending on the severity of the symptoms, we call it major and minor. Okay? So, in which cases it will be severe if more than two gene loci, if more than two gene loci are affected. Correct? It could be on the same chromatid. It could be on contra chromatid. Correct? In both the cases, it will be severe if more than two gene loci are affected. Okay? If it is like this is good, then it is severe. But if it is like, then it is minor. Clear? In case of major, there is chance of hydrops fetalis. In minor, person has two damaged or missing alpha globin genes. He is a carrier. Now, suppose this patient gets married with a normal person, then chance of having alpha thalassemia containing offspring is very less. But all the offspring, about 50% of the offspring will be carrier. In the possibility that next generation, if they go not by the medical rules, then problem. Correct? Alpha thalassemia is silent carrier and hemoglobin age disease. When a person has 3 damaged, age disease. ঠিক আছে, সাইলেন্ট ক্যারিয়ার কি হবে? আগে যেটা বলেছিলাম এই একটা ভালো একটা ভালো একটা খারাপ একটা খারাপ, সাইলেন্ট ক্যারিয়ার। কারণ কি this person need two alpha genes, one alpha gene he will get from this chromatid, another alpha gene he will get from this chromatid. So there will be no phenotypic changes much. Silence, mild anemia will be there. Mild anemia. So next time when you get mild anemia, can we go for thalassemia screening? We should. For a better society of tomorrow, we should screen every single child so that we know about their genetic makeup. But again, it's a costly matter, and half of the population of India is hand-to-mouth condition. Health comes next priority after food. Now, instead of asking hemoglobin H, they might ask you like this. What do you mean by hemoglobin constant spring? What do you mean by hemoglobin constant spring? I tell you, at this moment, you need to remember the terms and the definitions very well, because from afterwards, only these terms will be used along with the symptoms, along with the treatments, along with the management, everything. Then you cannot go back and find out, 1 minute sir, let me see what do you mean by hemoglobin constant spring, then I will go for the treatment. No. You have to remember it. I tell you, every slide is important, you have to remember it like you are reading A, B, C, D. That's all. These are very basic, very, very basic. Now, this slide will be easier to remember. Now, see, first one, all on chromosome 16. This negative sign means one of the gene is deleted or mutated. So, in one loci, two regions are correct. In another loci, one of the gene is missing or mutated. So, this has almost no signs and symptoms of thalassemia, although he is a silent carrier. This one, what do you mean by C? It's a difficult question. What do you mean by C? এসব করলে হবে না, ক্লাসে না শুনলে কিচ্ছু হবে না। কে বলতে পারবে দেখি? Anyone? Anyone who has listened from the beginning of the class, he can answer. What are the hotspot regions in the world for thalassemia? One of the hotspot region is Southeast Asia. Yes. Correct. So Southeast Asia. So here also like this, cis. Cis means like this. One of the chromatid is completely all right, another chromatid is completely gone. Next comes this, trans, cross, double deletion. Now this is constant spring. What happens to this? Hemoglobin bursts. In this case, there is the baby, the fetus does not survive. So there is hydrops fetalis. There are two subvariant of hemoglobin constant spring. Subvariant. Hemoglobin constant spring elongation discovered in Kingston, Jamaica, 2% of Thai have it. Now, when it comes to beta thalassemia, we have only two options because we have only one copy of gene. So either one of them is present or both of them are missing. If both of them are alright, then no issue. If one of them is missing or mutated, then it is minor. If both are missing, then it is major. Then what is this? Beta plus and beta 0. Plus means one of the gene is affected. 0 means totally no formation of globin chain. Alright? Now, what you thought to be less complicated has become more. Correct? ভাবলি আলফা থ্যালাসেমিয়া চারটের মধ্যে মাত্র এই কটা, বিটা থ্যালাসেমিয়া দুটো আছে নিশ্চয়ই কম হবে, তাই তো? এই যে সমস্যা। This is very difficult to figure out what type of genetic disorder is actually the patient is having. What we do, we just treat symptomatically. We try to rectify the anemic condition, overload of iron and other symptoms. Correct? But what is the actual genetic makeup? We don't know. Anyway, in this case, the silent beta thalassemia 2 plus means this is normal and this is mutated. 2 plus means mutated, okay? Thalassemia trait, these two are formed. So what is this B0 means? Okay, see on the board, this one, fine. This one, mild mutation has occurred, but the mutation has occurred which will affect mildly, not much, okay, in that case. Or it may occur like this, one of these is normal and another is totally absent. Okay, the gene is missing, totally missing. Huh? বুঝতে পারছি না বাবা। We call it trait. 50% is normal or 55% is normal. Say 56% is normal, 60% normal, 75% normal, but it is not completely normal or completely abnormal. 50% or more is normal. Now, half of the beta chains are being produced in this case, but with slight mutation. Suppose it has to carry 1 kg of oxygen, now it is able to carry only 70 kg of oxygen. Like that. So reduced activity. 2 signs means very less activity. 1 plus sign means little less activity. 0 means no activity. Clear? Thalassemia intermedia. See, now we have interface. Both the genes are affected. It is carrying oxygen but in a reduced quantity. These are the same. These two might fall under major or minor depending on the severity of the beta gene mutation. Now, these two, if the phenotypic issue is less severe, then this will come under intermedia. If the phenotypic issue is much more severe, then the same genetic elements will come under major. That's why I told you we separate them, we classify them on the basis of severity of the symptoms. If the symptoms are more severe, we call it major. The symptoms are more less severe, we call it minor. Intermediate, intermediate. Clear? Any question? Bolo. If suppose it's very difficult to make you understand. The actual genetic, if you want to see, you can go to for further reading any genetic group. But it happens so. Suppose there are two hands for catching oxygen, and to catch oxygen we need, say, 5 fingers. In one of the gene, only 2 fingers are functioning. In one of the gene, only other 2 fingers are functioning. In one of the gene, 2 fingers are functioning, not these fingers. Okay? Here only these 2 are functioning. Here these 2 are functioning, but with this we cannot hold. So like this, the severity might change from same genetic makeup to the phenotypic issue. Able to explain? Huh? So that is not well explained where and how it has been mutated. We go by phenotypic expression. Now we come to next, hemoglobinopathies. In general, we come to hemoglobinopathies, different types of hemoglobinopathies. One of the hemoglobinopathies you know already, called sickle cell anemia, isn't it? So we can classify the disorders on this basis: structural, functional, and production of hemoglobin. Structural, functional, and production of hemoglobin. Structural hemoglobinopathies with defective biosynthesis of globin chain. Then that means which comes under this? Defective biosynthesis of globin chain, thalassemia. Okay. This is hereditary persistence of fetal hemoglobin. Acquired hemoglobinopathies, structural hemoglobin co-inherited thalassemia. Okay. These are the examples of structural hemoglobinopathies. Just go through it. Already I have explained. When a new slide will come, I will tell you. Go through it and tell me if you have any queries. Because most of the slides actually were made, I tell you frankly, during the COVID period. And that time we had to take online classes. So there was less chance of having interaction. If we talk, no one will listen. In the classroom, no one listens. So back home, who will listen? So we had to make much more elaborated and explanatory slides. So we have to write everything in the slide. Whatever we speak is right. So now the COVID time has gone, but along with our speech is also gone. Correct? So I would request you to go through it carefully and ask me in case of any doubt. What over? Huh? Eta? These are usually inherited. Acha. Mutations of the following strategic regions play important role in the clinical manifestation of in the hydrophobic amino acid of surface. Sickle cell anemia. What happens there? The beta glutamic acid is converted to valine. So usually the hydrophobic chain are located outwardly, inwardly. In this case, the hydrophobic chain is located inwardly. So outwardly. So they cling to each other. The hydrophobic patch is formed. In the hydrophobic amino acid lining the internal heme binding core. In the interface amino acid lining the alpha 1, beta 1 or alpha 1, beta 2 surfaces. These are hemoglobin has been taught to you. So there are two interfaces in the globin chains. One is between similar chains, another between dissimilar chains. That means interface between alpha and beta, and interface between beta and beta or alpha and alpha. So which one is more stronger and which interface is weaker? You know, because there are two salt bridges in one side and there are only one salt bridge in other side. Okay, so they break in the dissimilar interface. বেশি হয়ে গেল? বেশি হয়ে গেল না? হ্যাঁ? কবে পড়ি সেটা আমার বলা কাজ নয় এখন। Potential F cells, the precursor cells from where the blood producing tissue or cells are produced. Take this slide. You need some names to remember. HBS, high and low, polycythemia, and low pseudoanemia, cyanosis. Hemoglobin that oxidize readily, unstable hemoglobin like hemolytic anemia, like methemoglobinemia and cyanosis. What is cyanosis? Cyanosis is not a disease, it's a condition. Many diseases may lead to cyanosis. Clear? So high oxygen capacity affinity is polycythemia, where the RBC production is increased, and here low. So this pseudoanemia. Hemoglobin is there, but it is less functional. So what happens? Looks like anemia. But hemoglobin content is right. Is it possible? Yes, it is possible. The hemoglobin content is all right, between 12 to 16 grams. But problem is with the function. Is it possible? Yes, it is possible. Very much possible. There are many diabetic patients whose insulin, if you measure, will be absolutely normal. Correct? Then why they are diabetic? The production of insulin is normal, but insulin is ineffective, mutated. Okay, production is normal, but insulin is ineffective. Three types. HBE or LEPOR, Osselping. এগুলি তোমরা পড়েছো, এগুলি তোমার হাই কি বলে অলরেডি ফিজিওলজিতে তোমার পড়ানো হয়েছে। পড়ানো হয়েছে ফিজিওলজিতে, হিমোগ্লোবিন, ব্লাড, হেমাটোলজি। এগুলি তোমরা হিমোগ্লোবিন এস্টিমেশনের সময় পড়েছো। বলো কি বলছো? দেখো পড়ে নাও। What is this and what is this? And carbon dioxide? Now investigations. Here it comes to our area. How do we investigate? What are tests we do? We can go for tissue biopsy, bone marrow biopsy. We can check the RBC morphology under microscope. We can look for inclusion bodies. Inclusion bodies means the abnormally sticky patch containing hemoglobins forming clumps called inclusion body. Usually the RBC should not contain any inclusion body. It has no organelle, why it should contain any inclusion body. Correct? But in abnormal hemoglobin, where there is a hydrophobic patch, they will cling to each other and they form clumps. Those appear like inclusion bodies under microscope in case of abnormal hemoglobinopathies. Hemoglobin electrophoresis. This is done with the help of cellulose acetate. Cellulose acetate. Cellulose means paper. Cellulose acetate means paper with a specialized function. The paper might contain many impurities which may contribute to certain electroendosmosis. To reduce the possibility of electroendosmosis, the paper, the cellulose molecules are charged with acetate molecules. Now, this provides an uniform negative charge throughout the paper surface. So, whenever the hemoglobin percolates through paper capillary pores, they are separated they are separated actually by their mass, not by any other interactions. So there is less interaction with the paper surface due to uniform charge, and bands will be more compact. Okay. Fetal hemoglobin. What is that? Alpha to beta 2, correct? Amount of fetal hemoglobin will be high in some of the hemoglobinopathies. PCR with hybrid, all the methods are not for detection of one type of disease. These are different methods for detecting different diseases. Do not get confused. PCR with hybridization. For what? For this purpose. To understand which one of these we need we need PCR. Okay, squid, fluorescence assay, iron overload. This is what you know very commonly. Glutamic acid convert to valine. What are the molecular method of diagnosis of the hemoglobinopathies? Isolation of gene of interest, analysis of gene function, detection of abnormality in isolated gene. These are steps. Now, where gene need to be isolated and function has to be tested, there are different methods, different tests are there. One of them is hybridization technique for isolation process. Molecular cloning. We have got only small amount. By cloning, we can increase an amount of gene. PCR for the same function. We are just multiplying the number of genes, nothing else. We had a very small amount of DNA. Now we are increasing the proportion of DNA which contains probably the faulty gene. We will multiply that portion only. Human genome is very big. So we will multiply the genome, only the portion which is affected, we think. For that, we need to first localize the region where the gene is located. For that, this technique. Then, by cloning, we can separate the portion, small portion, take it out. And then, by PCR, we can multiply the amount, step by step. Now, after this comes fish, fluorescent in situ hybridization. Any default mutation located in any of the chromatids can be identified by this technique. This is commonly done in molecular biology laboratory for identification of different diseases. Particularly to identify the cause of genetic cause of infertility, it is used mostly. What is fish? You might get as short question. Actually, this should have been taught afterwards, after you study the molecular biology techniques. Anyway, for the timing you understand like this. Different steps have been explained here. I will not go into detail because every technique will be taught in detail afterwards. Fish also will be taught, cloning also will be taught. You will have a separate class. Genomic library, cDNA library. Okay. These are, you just remember the names. So these are techniques by which we can form, we can identify the affected gene. That's all. Okay. Now, what is the takeaway knowledge from here? From here, you can get the following short questions. This class. Number 1. What is thalassemia? Classify thalassemia. Okay. In the classify thalassemia question, you have to answer both alpha and beta, major and minor. First phenotypically, then by genotype. Okay, that means you have to mention both, all this alpha series as well as this slide. And this slide. If you remember these two slides, sufficient. That's all. Now, then comes, what are the complications of thalassemia? What are the complications of thalassemia? Write down. Complications of anemia. Again, remember, severity of anemia depends on type, but anemia will be there. Okay? If not complete anemia, then pseudo anemia will also be there. Right? So, anemia, fracture prone bones, bone deformity, increased risk of infection, iron overload. কোনটা বল? Number 4 to now morning baba. Increased risk of infection, fracture prone bones, iron overload. দেখো অ্যানিমিয়াও আছে আবার আয়রন ওভারলোডও আছে, কন্ট্রাডিক্টরি, কারণ hemoglobin is there, it is being produced more, but it is ineffective. Iron overloadটা হয় বেসিক্যালি ডিউ টু রিপিটেড ব্লাড ট্রান্সফিউশন, তাই না? বারবার ব্লাড ট্রান্সফিউশন হয় বলে আয়রন ওভারলোডটা হয়। বুঝা গেল? পছন্দ হচ্ছে না কেন হচ্ছে বলো? এগুলো সিমটমস। ট্রিটমেন্ট কি হবে? নো ট্রিটমেন্ট, দেয়ার ইজ নো কিওর, অনলি ইজ প্রি ম্যারেজ genetic counseling. Pre-marriage genetic counseling. Whenever in this coming February you fall in love, before that you remember this class. Okay, all of you should get your hemoglobin screen. See, after all we are falling in love, we are making love, we are getting married. For what? To get children, to get our so children are not born or born with deformity, then it will be difficult. And that is why someone has told love is blind. Love never sees all these things. Love is blind. But you are not, you are a doctor, so be careful. You know, first you get the genetic counseling, then you go for marriage. You know? Okay, fine, you get married, you fall in love, you come to know that your would-be spouse is having kids. You can adopt anyone. You can adopt any child, give a child, give an orphan a good home, a good future. That's all. Right? You have to be large-hearted. Right? This is one. Okay. Anything else? That's all. That's all. So these two questions are important. Only what you have to remember, these 3-4 slides you have to remember. And these techniques, if you want, you can remember. What is the techniques? These slides. This slide you can remember, because sometimes they ask like this, general term. Write down about hemoglobinopathy, different hemoglobinopathies. Okay? So then this slide will be important. How do you classify hemoglobinopathies? Structural, functional, and production of hemoglobin. Okay? So there comes this classification. এমনি লিখেছি, টুকে টুকে লিখেছি। See, the secret to success is marks in the examination, correct? And secret to getting marks is you should know what not to read. Anyone knows what to read for any exam, but a good teacher knows what to teach. If I feel like, suppose I work with this particular topic, you will come to know that I know I have worked with this, because I will speak more, which is not required. This is, so you have to control yourself. Each technique, yes, different techniques are there. Some of the techniques will be asked. Hemoglobin electrophoresis will be asked. So what are the diseases detected or diagnosed by hemoglobin electrophoresis? Suppose this question comes. What will you answer? Sickle cell hemoglobin, then thalassemia, then what else? Fetal hemoglobin. All these are detected by hemoglobin electrophoresis. Then anything else? HbA1c, glycosylated hemoglobin. So see, these 4 parameters are detected by hemoglobin electrophoresis. Now each one has different implementation. HbA1c is seen for monitoring of diabetes. Monitoring of diabetes. Right? HbF for detection of cancer. HbS, detection of sickle cell anemia. And this one for thalassemia. Different diseases, same technique, different ways of separation. When they are separated, the interpretation is different. So different types of people will send you for this test. The people from hematology, they will send it for thalassemia identification. People from endocrinology, they will send the samples for HbA1c, monitoring of diabetes, like this. That's all. Any question? HbA1c, fetal hemoglobin. it is produced from liver in the fetal stage. When we take birth, the production of blood cells transferred to bone marrow from liver. In case of cancerous patient, these liver cells again regenerate. Suddenly they wake up from the sleep after 10, 15 years, 20 years, 30 years, and then we are diagnosed with liver cancer. Okay? Normally the cells should have been died, but in cancerous patient, they will wake up suddenly from the sleep. Any question? Thank you.
From the brachial plexus or individual nerves, the injuries, how to decode the injuries, where the problems are there, and these are also the clinical stuffs. That means in your clinical life, you are going to experience this particular clinical problems based on this particular clinical nerve injuries. So the upper limb injuries are quite common because this particular upper limb have the bones which are prone to have fractures, and if you have a fractures on them, we are likely going to have nerve lesions or nerve injuries. And if you have nerve lesions or nerve injuries, they are going to present with the muscular injuries, sensory injuries, etc., etc. So before we begin to this particular upper nerve injury, so maybe just like I will be going slow and or reasonable with the pace with this. Now, in the upper limb nerves, whatever we are going to deal with, they are mixed kind of nerves. So what do you mean by mixed nerves is the nerves have got motor functions and the nerves have got sensory functions. So they supply the skin and they do supply the muscles on them. That means may make the muscle to move, the parts of the body to move, and they also supply the skin region to take the touch, pain and temperature sensations. So those means if you have a nerve lesion, most probably or in a majority of the cases, we are going to have two kinds of lesions. One is the motor injuries. That means the muscle is not going to work. That's the problem, and if you have a muscle not working, that means the joint will have the problem with it. That means the movements of the joint will be accordingly hampered or compromised. The other thing which you often forget about it, or most of the time forget about it, is the sensory lesion. That means the skin supply. So whenever you're given the problem based on a nerve injury, you have to make sure to understand whether this particular nerve is a sensory nerve component is existing and a motor nerve component is existing on them or not. And then you have to write that if you have an injury to them, you have to say that the motor loss and the sensory loss. So the marks will be appropriately designed whenever you are given the question. Say for example, if I give you a question of radial nerve injury and consequence of the radial nerve injury, that means whenever you are writing the answer, you have to mention everything that includes the nerve injury, cytolution, how these things happen, and then you have to mention about the motor injury or motor loss and the loss on the muscles or actions. And second thing is the sensory loss. So if it is given 4-mark questions, 2 and 2 or 2.5 and 1.5 will be appropriately divided on them. So if you forget to write the sensory, you will be just like a judged on only 2.5 out of the 4. So out of 2.5, no matter good how you write, you are not going to make a score which is more than 2. So in a 4-mark question, you are writing everything on it on the motor loss, you will be just getting 2 because you forget to write about the sensory loss. So sensory loss, you have to write the right answer and the motor loss accordingly whenever you are going to do that. Now, coming to the nerve injuries. So we learned about this particular nerve injuries, started with this particular complex diagram, we call them as brachial plexus. So our brachial plexus is a nerve plexus which is present in this particular upper extremity and a part of the neck region, and this particular region we explored through dissection as well, and we've seen this particular plexus to some part like cords and the branches of the cords, etc., in this region, and further when I'm going to do the dissection in the neck region, we'll be coming back to this particular brachial plexus network once again. But In an exam, we will be giving the questions on brachial plexus or injuries on the brachial plexus in the upper extremities. So, this upper extremity question will be composed of this particular brachial nerve injury or brachial plexus nerve injuries. Now, there are three entities in the brachial plexus which are the nerve lesions or nerve injuries are concerned we will be dealing with. So, one will call them as upper trunk injuries, one we call them as lower trunk injuries. These are the two trunk injuries, and then we have a nerve which to deal with, which is present in here in this region. We will be dealing these three nerve injuries in a brachial plexus. And then once we deal with the injuries on the brachial plexus nerves, then we will move to the individual nerves and injury on them. So that's the plan. So we'll be covering this particular brachial plexus injuries, then we'll move to the nerves. We have three major nerves to cover here: radial nerve, ulnar nerve, and this particular median nerve, which are things which are big chunks. We have to know about them. And before that, we have the axillary nerves, musculocutaneous nerve. These are the individual nerves. Now, each of these nerves, injuries to them could be your exam question, or maybe it may be summarily 10-mark question, includes everything starting from the drawing of the brachial plexus, starting from in and out, everything. So you have to prepare this thing very well. It could be university exam, you could be in a final grade exams, everywhere it will be there. And moreover, this is your life thing. This is you are going to see, explore in your clinical life as well. Alright? So just like a quick recap of the things where we are starting over here. So the brachial plexus consisting of this particular nerve which is coming from the ventral RMI C5, 6, 7 and 8 and T1, and coming with the networks joining upper and this one going down, joining and again splitting anterior posterior division, then posterior divisions and this particular lateral cord and this particular medial cord. They are severally dividing into branches. We should be able to draw this particular schematic picture very well, because this is one of the exam question with the schematic picture drawing as well. And we have done it a number of times, and I have mentioned it innumerable times about, be sure about whenever you are just like getting a free time, you should be able to draw 18 or 19 nerves which are coming from it. Now, the first problem of this brachial plexus injury, we will be talking about this particular injury. We call them as upper trunk injuries. So this is the upper trunk C5, C6, and then C5, C6 uniting together, making this particular root to this particular trunk, and then it divides into anterior and posterior division. Now you focus at this point, we call this particular area where I am rolling the cursor over here as Arb's point. So here is a union or a kind of place where you can see 6 nerves coming out. So C5, C6, these are the 2 nerve roots and 2 of the branches which is going on, suprascapular nerve SSN and nerve to subclavius 3 and 4, and then is the division, anterior and posterior division. Now this region where I am just saying here, this is known as Arb's point, ERBS, Arb's point. Now we could have a lesion at the Arb's point. Now this region is lying on the upper part of the neck and the junctions of the neck and the upper limb. Now how could one individual could have an injury to this particular upper part of the neck and injure this particular point and ripping the nerves over here? So there are circumstances where we could have injuries to that particular Arb's point. Starting from this child delivery and to this particular adulthood or adult life, we might have and chances of injury to them, and we should be knowing the circumstances where we could have an injury to them, because the patient may be coming with the road traffic accident unconscious, cannot give any history whatsoever, and you have to figure it out looking at the posture. It could have an injury to the nerves depending on how the patient is lying. So you have to be judgmental, and accordingly you have to be instrumental in finding out the injury. Now, starting with this particular Arb's point injuries or Arb's point, this is what we are talking about, the kids which might have this kind of problem. And this particular problem in the kids many a times are hidden, buried, because the kids are born with some kind of like a birth injuries, and one of the birth injuries could have an issue with this particular Arb point lesion. And once again, you have to design this Arb point with this schematic diagram. So this is the Arb's point. You have to draw a schematic picture. You may not have to write this kiddo in your examination because that makes no sense. But you have to draw this particular schematic picture, right? So about the drawing about this particular anatomy picture. I remember we got a question in our examination where we didn't know anything about it, about some question. So there was one of my friends said that I do not know anything, let's do something, they draw a picture. So there is a picture of ova or parasites or something was there. So he didn't know anything about the ova or parasite or those embryologic or those particular microbiological pictures. What he could do, he draw a picture of a man looking through a microscope and examining it. Full landscape picture. But we do not expect that. He eventually, after drawing it, got a big 0. So that makes no sense basically, right? Even if you draw a picture, if it is not related, it's not going to find a marks in it. So coming to our point. Now coming to this particular acquired injuries, what could have lesion over there? Now we have an angle between the neck region and the arm. So arm neck angle is there. So if by any chance, if you have an excess arm neck angle which is exaggerated, that could have ripped this particular orbs point. Louder, more. ওই অন্য তুমি কি একটু গ্লুকোজ দিতে পারবে এটাতে বাড়াতে পারবে? So we could have an injury over here because of the overstretching of the neck. Now how this overstretching of the neck could have affected during the childbirth? So normal the child borns with this head presentation, right? So when we are born, we are coming out of this particular mother's womb like this through the head presentation, right? Now we assess this particular childbirth process. Now thing is that sometimes no treatment is the right treatment. So we have to know when not to treat it. So when this baby is coming through this vaginal way, through this head presentation, we have to wait until the head comes out. So the head should be coming out, we shouldn't be holding the neck and head like this and pull it out. And many of us will be doing in our clinical life, oh the baby is just like suffering too much, let me help you out and grab his head and take it out. Oh, that's a problem. That's why I'm saying sometimes no treatment is the right treatment. So sometimes you have to hold your nerve and wait till it comes out. Let the head come out. Then you have to take the shoulder, not this neck region. You are not allowed to hold this neck, not allowed to hold this particular face region, or neither you can hold this particular neck to grab it out. You have to wait for here in this time till the neck comes out, and then you have to take it out holding the shoulder and take it out. Now if you are too enthusiastic in helping it out and grabbing this and pull these things, and you can see that there is an angle which is between the neck and this upper arm is increased. That means you're ripping this nerve which is present in the orbs region or orbs point. So that's why we have an injury of the nerves, orb point breakage. It could have a breaking the C5, C6 roots itself, or maybe just like a ripping this nerve which is present in this region, and bringing or creating a nerve lesion. Now in a kids, this particular nerve lesions may not be present immediately after birth, because the kids do not have that much of muscle movement at that point of time when this particular kid is exercising or doing. After this particular kid grows to this particular 1 year, 2 years of age, they will have a deficiencies. So that particular deficiency will be having, the arm will be extended forever, will be medially rotated, and it will be just like a tip top over here. So it will be like presentation. With this kind of injury, the kid presents with a kind of injury, we call them as orbs point injury, which is like this. So arm will be hanging straight and twisted medially and will be turned down. So this is the injury that patient present with. Now this is about the injury which is occurred in kind of childbirth for the kids. How about the injury in adult life? The person falling from height and again falling on the shoulder and extending the neck like this. So falling from the work, mostly the worker people working on the heights, cleaning stuffs or doing something, they are falling from height and injuring by making this particular angle over here at the same thing. the angle between the neck and the shoulder and the arm is extended and stretched, and that again stretching that particular nerve which is present at the arch point. So again that's a thing which is happening over here, the ripping the nerves at that particular point which I mentioned where the 6 nerves are coming. C5, C6, nerves to subclavius, and all these nerves which are present on here, injuring or damaging the upper trunk of the brachial plexus C5, C6. Now, the problem we have identified, how this thing happened, we have identified as well. Now, we are going to decode the problem, how this particular nerve lesion is affected the muscular function. Now, the muscle fibers which are affected out here is because of this particular C5, C6 nerves are contributing the majority of the fibers to 2 of these major nerves. One is the axillary nerve and other is musculocutaneous nerve. So, the fibers which is present in the upper trunk C5, C6 predominantly composed of or constituting of this particular region as axillary nerve contained and this particular musculocutaneous nerve contained. That means we have a lesion which is predominantly lesion affecting the musculocutaneous nerve action and the axillary nerve action. Now what I have to do next? We have to know what the musculocutaneous nerve is supplying to, we have to know what the axillary nerve is supplying to, and accordingly there will be nerve lesion which will be like present over here. So take one nerve, we take the musculocutaneous nerve. So musculocutaneous nerve is supplying the motor actions and the sensory action. So musculocutaneous nerve, which are the muscles supplied by the musculocutaneous nerve? So BBC, biceps brachii, coracobrachialis and brachialis. What the function of those muscles? They are flexing the elbow. So the flexion of the elbow will be deficient, right? The arm will be extended. Correct? So the extension of the elbow will be there. There will be sensory loss. The musculocutaneous nerve supplies the lateral aspect of the forearm. So there will be anesthesia, paresthesia on the lateral aspect of the things. This is about the musculocutaneous nerve. What is the other nerve affected by this particular upper trunk lesion? Axillary nerve. Axillary nerve supplies predominantly 2 muscles. One is over here, is the deltoid. What is the function of deltoid? Abduction. That means we are stretching the arm over here in this region. So this particular shoulder movement or abduction or spreading the arm will be deficient. That's why the arm will be placed over the trunk or the body. This is the one thing. These are the 2 prime things. Now what are the motor actions over this particular axillary nerve? It supplies the skin over the shoulder tip region or this particular deltoid domain. So there will be anesthesia, paresthesia over this deltoid region, numbness over this region, lateral aspect of the forearm. These are the 2 prime things that we have to focus about this upper injury of this brachial plexus trunks. Now, other than this, we have some fibers on this region going to supply to another muscle which is known as SSN, which is suprascapular nerve. So that particular suprascapular nerve supplies 2 muscles, supraspinatus and infraspinatus. The function of the supraspinatus is to move this particular shoulder region or this shoulder abduction, initiation of the shoulder abduction. So that means the abduction action of this particular shoulder region is completely gone because of the deltoid and the supraspinatus is not working. So this is the lesion we will be having in this particular patients. Loss of abduction, paralysis of the deltoid and the supraspinatus. And why? Because of this SSN and AXN is not working. Suprascapular nerve and the axillary nerve is not working. And there will be sensory loss accordingly. There will be loss of flexion at the elbow joint because the BBCs are not working. Who supplies the BBC? Musculocutaneous is not working over here. So we are not having this kind of lesions. Loss of external rotations and the supraspinatus and this infraspinatus are the muscle which are basically moving this particular shoulder towards the outer side. That means the lateral rotations or these external rotations are there. So these particular actions of the supraspinatus, infraspinatus are not there. So that's why this particular person will have a deficiency. What will the symptom? The arm will be dropped, hanging by the side of this arm, strung, rotated medially because the lateral rotators or external rotators are not working. Elbow is extended because the BBCs are not working. Shoulder joint is adducted. That means the abduction is not there because the deltoid is not working. So shoulder joint is plastered against this particular trunk. So it is pulled towards the body, and this particular person will be arm hanging by this trunk and cannot move or cannot bend it at the elbow joint. So we have to justify each and everything what is muscular deficiency is happening here and why this muscular deficiency is happening there. At the same time, you have to mention about the sensory losses. So this is the complete answer. And this position of the arm, we call them as waiter's tip or policeman tip position. Now what do you mean by the policeman tip? So if you are caught in the wrong hands doing something wrong, you have to bribe the policeman. You cannot say, please take this and go leave me, right? So you have to just like sir it to like that, right? So you have to be smart in bribing people, right? So this is the first lesson of how to bribe. So go to these particular primitive positions and bribe. So that's why we call this as policeman tip positions of this arm in the abdomen specialist. So this is one of the most commonly been tested in examination upper limb injury which is affecting this brachial plexus or this particular brachial plexus injury affecting the upper region or upper trunk. So whenever you given this particular question itself, it's a 4-mark question of palsy. That means you have to mention the lesion, where this lesion is there, what are the nerves affected, and what are the loss which are going to experience, and what are the symptoms at the same time. So how would be the positions of the arm? Everything over there you have to narrate, and they are very, very clinical about it. They are very, very kind of like precise about it. You have to write the symptom, loss of nerves, etc., etc. Then you can get the marks. And again, this is a rather easy thing. It's kind of just like a maths. If you just like write it, you will get the marks. If you fail to write it, you won't be getting marks. Okay? So this is one of the lesions or one of the injuries that has been commonly been tested in examinations. We call this particular problem as abduction paralysis or Orb's point injuries. So in adults, in kids, how these particular injuries could have happened, and what are the nerve injuries, what are the positions of the arm, and why these particular muscles are not working, and why this arm position is there, why there is a sensory loss depending on which area we have to know about. Good? Okay? This is going to be tested in examination. Will you be able to write it? Then I am not going to give it, right? So second injuries, again the brachial plexus. So you have learned the injury which is happening here in the upper region or upper part of the brachial plexus. So there are injuries which is affecting the lower part as well. So there are injuries which is the lower cord injuries of the brachial plexus. That means C8 and T1, they are ripped over there. So we call them as plum crease paralysis. Plum crease paralysis affecting the inferior trunk of the brachial plexus, C8 and T1. And again, the same thing, how this particular injury could have happened. In case of the kids, in case of the adults or grown up. So in case of the adults, 2 adventurous people, you see that? Hanging by the wood stick like this, or on a mountain reef or like something like that. So person is falling and try to grasp a hold on something and hanging over there, and this particular thing rips this particular thing, which is increasing this particular angle which is lying in the lower part of the arm and the trunk, ripping this particular lower trunk of the brachial plexus. This could have happened, or this is one of the reasons which can happen. Second thing, in the kids, once again, during the childbirth. So we have said that in the normal childbirth, the fetus presents with the head. Sometimes there is an abnormal presentation. Instead of the head, the hand comes out, just like Hitler. The hand comes out, and say the hands is coming out, and just like for a shaking of hand, you grab it and pull it, and again the same fate. You rip the nerves in the lower trunks of the brachial plexus. So you injure this particular C8 and T1. So that particular nerve is injured. So there is a chance causes of injury, undue abductions of the arm, which could have been stretched because of this particular the falling from height and grasping on it. It could be one of the reasons. or maybe an extra rib over here, we call them a cervical rib, that could have just like a compressing this particular T1 or CA-T1 this region, or a lymph node maybe, they will be compressing over there, or maybe just like a tumor compressing over here in this particular apex of the lung, that could have happened, and compressing this particular thing will be damaging this particular thing, which is CA-T1. Now this particular CA-T1, the fibers which are coming over here predominantly heading towards a nerve which is forming the ulnar nerve. So the ulnar nerve, which is a nerve going to supply all the small muscles of our fingers. That means our small finger actions, whatever we are doing, holding the pen, buttoning the shirt, grasping something, any sophisticated work, whatever we are doing with the fingers is because of this particular muscle which are working. We call them as intrinsic muscles of the hand. They are supplied with this ulnar nerve. So that's why this particular nerve we call them as musician's nerve. So because it's a kind of needs a delicate actions. So this particular CA-T1 fibers, they are predominantly heading towards this particular nerve, which is the ulnar nerve, and if they are ripped, we are going to have a deformity. We call them as claw hand deformity. It's not like like Shomik is showing going to claw you like this, right? It's not like that. So what is a claw hand deformity? So claw hand deformity, whenever you are asking the patient to make a fist, you are asking the patient to make a fist, they cannot complete the fisting, and they end up in the process of fisting, they end up like this, and their movement is happening here. So they are looking like a claw of a hand. That's why they are known as clawing of hand. So they are not going to walk down the street with claw hands like this. They will be having normal hands. Only when you ask him to make a fist, and they will be making a fist instead of this, they will be making a claw. Then it will be just scared. Oh, claw, wolf claw or something. So, once again, the clamp cleats paralysis, how it is happening, the injuries, which are the nerve fibers, they are ripped. You have to mention what are the circumstances you have and what are the deformities and how this particular deformity is coming with. Now, they are mentioned as before, there will be a motor deficiency, that means the small intrinsic muscles are not going to work. So, whenever I am going to talk about the ulnar nerve injury, I will be discussing about the detail of the small hand muscle actions, not here over here. So, this claw hand is a loss of innervation of the intrinsic muscle leading to this particular claw hand deformity. That is a motor deficiency of the ulnar nerve. Second, the same thing, the sensory, the loss of sensation on the medial side of the hand. So, this medial side of the hand is supplied with the sensory supply to this particular ulnar nerve, and there will be loss of sensation on them. So, there will be a deficiency due to loss of this particular ulnar nerve, of the sensory deficit and the motor deficit as well. So, this particular claw hand deformity, which is happening because of the clamp cleats paralysis, is one of the another important clinical problem that we encounter in the brachial plexus injuries. So, again, you have to just like mention accordingly, and everything you have to mention. You have to draw a picture of this particular brachial plexus, mention the site of injuries in a schematic, you have to mention the causes of injury in adults and kids, and deformity, that means the motor deformity and the deformity postures like clawing of hand, and why there is a clawing of hand which is included over here is because of this sensory loss and as well as the motor loss. Now, one thing along with these particular motor injuries, we have another symptom, we call them as Horner syndrome, which could be associated with clamp cleats paralysis, but I am not going to mention it right now. We keep it for the next session when we will going to learn about the neck, when we are going to talk about the muscles of the eyes, then we will talk about this Horner syndrome, then we come back once again about this particular brachial plexus lower cord injuries, and we will just like come and associate these things at that particular point. So, at this particular level, we just like stop our discussion over here about this claw hand and the sensory and the motor loss on the clamp cleats paralysis. Horner syndrome, we just like let go for now. We will come back about Horner syndrome in the next session. So, this is about the brachial plexus, true hardcore brachial plexus injuries involving this particular cords. Now, Coming to another brachial plexus injuries, we call them as injury to the serratus anterior. So we move back to this particular picture where we have seen this particular brachial plexus. So this is a brachial plexus picture over here we have seen, and involving this particular C5, C6, C7, we have a nerve coming down which is going line. We call this nerve as a long thoracic nerve, right? So that particular long thoracic nerve hangs by this particular rib cage, goes all the way down, and supplying a muscle, we call them as serratus anterior. We call them as serratus anterior because they look like a serrated, the margin look like serrated, that's why they are known as serratus anterior. So they take an origin like sleeves. There are 8 sleeve like or 8 finger like origin is there. From these particular ribs they are taking origin and moving to the back. And once they are moving to the back, they get attached to this medial border of the scapula. So we have the scapula, right? The scapula had a lateral end and has a medial end. So the medial end on this on the ventral aspect, this particular serratus anterior is anchored to. Now this particular injury which we are talking over here is the injury which is involving this particular nerve which is known as long thoracic nerve. So the nerve which is known as long thoracic nerve is present on the medial side of the chest wall or medial side of the axilla. Now how come this particular serratus anterior or just nerve to long thoracic nerve could be damaged? So how on the medial side of the chest wall this particular long thoracic nerve could be damaged? How an injury to the long thoracic nerve could be possible? So most of the time this injury which is happening in the long thoracic nerve is happening during surgery. What kind of surgery? When you are involving this particular mammary gland surgery, when you are involved in the surgery in the axilla, lymph node dissection or any kind of mammary gland dissection or mastectomy, those surgeries. During that time, you have the injury to this particular long thoracic nerve because that is present on the lateral side going down on this particular chest wall. So you have injury to this long thoracic nerve. That injury to the long thoracic nerve makes this particular muscle which is anchored to the medial border of this particular axilla over here in this region, which is present in serratus anterior anchored over here. So there is a weakness of this particular muscle which is serratus anterior. Now the actions of the serratus anterior is pushing and punching. So that helps in pushing and punching. So whenever you are pushing, this particular muscle is working. Whenever you are punching, this particular muscle is working. That's why this particular muscle, serratus anterior, is known as boxer's muscle. So this particular long thoracic nerve is gone, serratus anterior is gone. That means we have a weakness over here on this particular serratus anterior. That means their person will have a weakness in the pushing and punching. Now how we are going to elicit this? How we are going to examine this particular injuries is happening there or not? So this kind of injuries, if you are happening, you ask the patient to push the wall. If you ask the patient to push the wall, the medial border of the scapula pops up. So this popping up of the medial border of the axilla is known as winging of scapula. So this particular winging of scapula which is happening over here because of the non-action of the serratus anterior muscle, because of this injury to the long thoracic nerve which is happening, and most common kind of injuries which is happening over here is because of the surgical injury which is happening during this particular chest wall or this particular axillary surgeries. So this is again serratus anterior and this particular winging of scapula, how this particular things is happening. That's the thing which you have to just like figure it out and just like reflect on. So these are the 3 entities which is involving the brachial plexus, the injuries of this particular nerves, which could be just like important aspects that you have to need to reflect over here. Now coming to another nerve which is like a true nerve which is present in these particular the cords or branches of this particular cords, which is known as the axillary nerve. Now this axillary nerve has a particular location in this particular region. Now you see that This particular axillary nerve which is coming over here is the posterior cord branch and wrapping around or present around this particular part of this humerus. We call them a surgical neck of the humerus. Along with this particular surgical neck of the humerus, we have this particular axillary nerve winging around. So, by any chance, if you have a breakage of the surgical neck of the humerus, so if this particular surgical neck is broken and ripping this particular thing is leading to the damage to this particular nerve. So, this axillary nerve entrapment or injury is happening in case of the fracture of the scapula and fracture of this particular surgical neck of the humerus. The surgical neck fracture is one of the commonest happening in the female subjects in the elderly at the elderly age. So, you have an injury to this particular fracture over here, surgical neck, and the patient have an insult or kind of injury to this particular region. We call them as this axillary nerve damage or axillary nerve injuries. So, you have an axillary nerve which is present in this particular region, triangular quadrangular space, and along with have this particular fracture over here. This could be one possible reason where this particular axillary nerve could be damaged, fracture to the surgical neck. Second, you might have a dislocation of the shoulder joint. The shoulder joint was placed in the glenoid cavity, slips out and hangs down to this particular region under this particular neck of the scapula, and at that region as well we have a chances of injury to this particular axillary nerve. So, there are two occasions where we have chances of injuries to this axillary nerve. So, if you have an injury to the axillary nerve, there will be a consequence over there, motor injury and the sensory injuries. Motor injuries, the muscle which are supplied by this axillary nerve, they are not going to work, predominantly the deltoid. So, deltoid is not working, teres minor which is a minor muscle is not working as well, and these are the two things which is happening over here in this region deficiency. So, if you have a deltoid muscle injury, there will be loss of abduction, that means the shoulder joint cannot be spreaded over here lateral aspect. So, abductions of the shoulder joint or spreading of the shoulder joint won't be possible in this particular individual, and because of the teres minor, it's a kind of muscle which is present behind the shoulder joint, there will be just like a loss of action on the lateral rotation. So, this arm external or lateral rotation will also be deficient. So, the lateral movement and lateral rotations which are going to be affected is the motor function deficiency. These are the two things which is happening in case of these injuries to the axillary nerve. Now, coming to the sensory action, the skin over this deltoid region, over this shoulder region, they are supplied by this particular axillary nerve. So, there will be anesthesia and paresthesia of the skin which has been supplied over there. So, you see this particular region on the shoulder region which is number 2 anteriorly and posteriorly. So, the skin supply on this particular shoulder region both in the front side, lateral side and the back side will be deficient in case of the sensory sensation picking up functions. So, there will be sensation loss on the axillary nerve injuries, there will be motor loss in this particular axillary nerve injuries. So, these are the two consequences which are happening in case of this particular axillary nerve injuries. Now, from this axillary nerve, we are going to talk about the radial nerve. Amongst these big nerves, this is one of the commonest or kind of easiest nerve to deal with the nerve injuries are concerned. So, radial nerve which takes origin from the posterior cord, root value which is starting from the C5 to T on, everything is placed in here. All the nerve fibers are coming from all the spinal nerve roots. Now, the functions of the radial nerve is to supply all the muscles in the back region. So, everything on the back side, in the arm, in the forearm, is everything is supplied by or supplied with the radial nerve. This is the motor actions which is supplying everything on the back side. Along with it supplies the skin supply on the back side, back of the arm, back of the forearm and back of the dorsum of the hand is supplied by the forearm by this particular radial nerve. So, this is the distributions of the radial nerve which is lying on the back side. Posteriorly, the red domain which you are seeing here, the red domain which is the radial nerve branch. Everything on the back side including the dorsum is this red line which you are seeing here. This is a sensory innervation of this particular radial nerve. So, this radial nerve which is supplying the skin of this particular domain and as well as this, all the muscles in this particular back side or extensor side of the forearm and as well as the arm will be deficient if you have an injury to the radial nerve. Now, coming to this particular radial nerve injuries, where could have this radial nerve commonly gets injured in this region? So, the radial nerve hangs here in the region on this particular mid shaft of this humerus. We call this particular mid shaft region, which is known as spiral groove, also known as the radial groove. So, this particular spiral groove or radial groove, this particular region, we have this particular radial nerve lodged here. So, by any case or by any chance, if you have a fracture of the shaft of the humerus, so this particular radial nerve present in the spiral groove could have been trapped over there. So, if you have this particular radial nerve trapped over here because of the spiral groove injury or compression of the radial nerve because of this shaft fracture, we could have a chances of this injury or palsy to this particular radial nerve. Other reasons why this particular radial nerve could be trapped over here, which could have this particular crutch, holding this crutch like this, or abnormal positions of these particular arms, which may be just like holding this particular spiral groove against kind of bony matters, which is improper sleep, or kind of holding with this some kind of like a tough material in this particular abducted arm, prolonged applications of tourniquet. Sometimes it happens in our clinics. We are drawing the blood from the arm, we put arm tourniquet over there and forget to take it out. And then also that could have damage to this particular spiral groove nerves, which is leading to the radial nerve palsy. So these are the things which could have happened over there. So radial nerve, if it is damaged, if it is involved, we have a motor deficiency. All the muscles on this extensor surface of this forearm and as well as this arm region is not going to work. So the wrist will be dropped over here. We call them as wrist drop because the extension of the wrist is done by the muscles on the back side. So this extension action of this particular wrist is not there. So this is known as the wrist drop, which is happening over here. Second thing, sensory loss. All the areas which has been supplied by this particular radial nerve beyond the nerve lesion will have the sensory anesthesia, paresthesia or numbness will be there. So this particular dorsum of the forearm or dorsum of the hand will be have a numbness or sensory deficit if you have this radial nerve injuries. So once again, injuries to the radial nerve, how this particular radial nerve commonly gets injured, what are the common sites, spiral groove fracture or compressions of the nerve at the spiral groove or kind of like an injury on the spiral groove by compression on the chair or kind of like a holding a crutch for a long period, tourniquet, and resulting in kind of injuries which is leading to this particular drop of the muscles or muscle motor loss, which is known as this particular wrist drop because of the inability to extend the wrist. We call them as wrist drop compared to the same thing we have experienced in the foot drop where common peroneal nerve is damaged and sensory loss which is affecting this particular area of this particular skin supply of this particular radial nerve. So all the nerve injuries which we have mentioned over here are kind of very exam important areas, will be tested in several exams, given MCQs or given kind of clinical questions or a long questions or a fractions of long questions. So this is the first part, and next we are going to leave with this particular radial nerve. We are done with, we are going to talk about the median nerve injuries and the ulnar nerve injuries in the subsequent sessions. That covers all this particular and along with a little bit of a musculocutaneous nerve injury as well. So that covers everything nerve injuries in the upper limb. So the nerve injuries are kind of very important areas that you need to prepare very well for your examinations. So that's all for the day.
Previously we performed the practical review. Okay, all of you know the procedure then? There is slightly change today, but we are again doing this practical same, but some of the changes are there. Some of the changes are there. Today you perform this practical separately in a pair. Pair means two students perform this practical. Understand? And only two pairs can make 3 test tubes. Means what I say, only 2 can make the blank, and rest of them perform one for test and distribute. Understand? ओडी जो ब्लैंक की ओडी होगी वो मैं आपको दूंगा, उसमें आपको रिएजेंट आपको वेस्ट नहीं करना है. यू हैव टू जस्ट परफॉर्म एक ओडी ऑफ टेस्ट एंड ओडी ऑफ स्टैंडर्ड, ओडी ऑफ ब्लैंक. 2 स्टूडेंट परफॉर्म करेंगे, वही ओडी सब लोग ले लेंगे, क्योंकि वो ओडी ब्लैंक की नियर बाय सबकी सेम ही होती है. ठीक है, तो वही हमें आज करना है. सब लोग समझ लो ध्यान से. Today all of you perform this practical in a pair, and we also take the Bible of this group of from carbohydrate metabolism and also from your practical syllabus. That is all the things which is related with the glucose I will ask in the Bible. Okay, after performing practical you will sit on your seat and revise it. Whatever you do. ठीक है, अब एक्सक्यूज देना बंद करो. एक्सक्यूज, नया कॉपी पुराना कॉपी सबके पास मोबाइल है, बुक है, पीडीएफ पढ़े ना, उससे रिवाइज कर लेना 10 15 20 मिनट. टेस्ट की जो वैल्यू आती है पहले तो प्रैक्टिकल करो. प्रैक्टिकल अच्छी तरह करने के बाद जो आपका वैल्यू आता है उससे रिलेटेड पूरा पढ़ना है. आपको हंसी नहीं आनी मैडम. देयर इज समथिंग जोक आई विल टेल. सब लोग हंसी हैं, तुम लोग क्यों नहीं हंस रहे? हम लोग हंस नहीं रहे, हंसना लगे. क्यों हंसी आ रही है? कुछ याद आ गया? बाबा पैसे आते हैं. ठीक है, तो आपका जो भी है कार्बोहाइड्रेट मेटाबॉलिज्म से, डायबिटीज से, रेगुलेशन ऑफ ब्लड शुगर से, काफ़ी इंपॉर्टेंट थिंग सारी वो सब कुछ रहेगी. ठीक है, आपको पढ़ना है, 10-15 मिनट अच्छा फायदा देना है. और आपके एनाटॉमी में डिसेक्शन कॉम्पिटिशन का क्या हुआ? हु इज द विनर? किसने जीता कॉम्पिटिशन? राकेश. राकेश है ग्रुप में मिला. ग्रुप को मिला.
3 लोगों को विनर बनाया, 3 लोगों को फर्स्ट रखा, 2 को सेकंड.
हमारा मिला सेकंड.
तो कॉम्पिटिशन में नहीं था, सबके साथ झगड़ा करके आउटसाइड कॉम्पिटिशन थे. वो मिला एक सर्टिफिकेट.
बाकी ग्रुप पार्टिसिपेट करें कि नहीं करें?
तब वो बोला था ना काटना तो बस करना चल जाए.
अभी टाइम रह गया है कम आपका. ठीक है, यूजी की एग्जाम यूजी एग्जाम इज ओवर एंड काउंसलिंग इज स्टार्ट.
ये मौसम का एग्जाम तो फाइनल एमबी के बाद होगा, गोल्ड मेडल के लिए बाद में होगा.
तो मेन क्या है ना, अभी आपका टाइम कम रह गया एग्जाम के लिए. नियर बाई जनवरी में एग्जाम हो जाएगा. जनवरी फर्स्ट ठीक है, तो आपके पास कितना टाइम रह गया? सितंबर इज ओवर. अक्टूबर, नवंबर, दिसंबर, only 3 months. And there are lots of flavors. If I talk about the biochemistry, there is mineral metabolism is over. I think in the human then molecular biology section is started. Very important section. After that, nutrition, cancer biochemistry, immunology, all these important chapters is covered. And up to this, you are not complete the metabolism at this time, then you face some main problems. I will talk about the final exam, not about the semester. Okay? थोड़ा थोड़ा भी पढ़ना चालू कर दो, रिलैक्स होकर पढ़ाई करो. अब पढ़ना है. There is no other things rather than study. जी? आप लोग क्या है ना, जो चाह रहे हैं, आप ये चाहते हैं कि मेन कंटेंट, सॉलिड कंटेंट आपको दिया जाए कि इतना हम पढ़ लें और दिस इज सफिशिएंट. डोंट स्टडी लाइक दैट. आपके पास बुक है, पढ़ो 10 ईयर की क्वेश्चन पेपर निकालो, पहले 10 ईयर के क्वेश्चन पेपर को निकालो, फिर मैं आपको कंटेंट दूंगा, ठीक है। वो कंटेंट आप पढ़िए, सारी चीज़ पढ़िए और आप तसल्ली पक्ष पढ़ते चले जाइए, कॉन्फिडेंट डेवलप करो। अगर आप पढ़ोगे तो कॉन्फिडेंट आएगा। जो लोग की मार्किंग थोड़ी कम है, जो लोग सी ग्रेड में आए हैं या डी ग्रेड है या बी ग्रेड है, उन सब स्टूडेंट्स से मैं यही कहना चाहूँगा कि कंटिन्यूसली स्टडी करें, दे स्टडी रेगुलरली विथ मिनिमम टाइम ऑफ आवर्स, डोंट वेस्ट टाइम हियर एंड हियर सिटिंग इन दिस कॉलेज कैंपस। अपना टाइम यूटिलाइज करना सीखो। क्लास में भी अगर आ रहे हो, इफ यू आर कम इन द क्लास बिफोर 15 मिनट्स, बिफोर 20 मिनट्स, यू विल ओपन योर बुक, रीड इट, व्हाट द टीचर स्टडी, पुराना पढ़ो, ठीक है, जो पुराना पढ़ाया वो पढ़ो, जीओडी पीओडी पढ़ लो, ओजीटीटी पढ़ लो, डिस्लिपिडमिया पढ़ लो, मायोकार्डियल इन्फेक्शन पढ़ लो, डायबिटीज पढ़ लो, जितना टाइम मिल रहा है उसको यूटिलाइजेशन करना सीखो। अभी ये नहीं करना है कि हमको 5 बजे जाके पढ़ना है, जब when will class is over I will go to the home and go to the room and started my study at sharp 5 o'clock. Don't make a timetable. Now the time is what? Go study. कभी आयरन का कंसेप्ट सुना है? लोहे का क्या कंसेप्ट है गर्म होने का? क्या है उसका?
जितना जल्दी गर्म हो उतना जल्दी उतना अच्छा साइज है।
हैं?
जितना गर्म करेंगे उतना साइज
नहीं,
जितना जल्दी गर्म होगा उतना जल्दी ठंडा हो सकता है।
नहीं ऐसा नहीं। लोहे का कंसेप्ट ये है कि वो एकदम अगर उसको हीट करेंगे तो एकदम हीट नहीं होगा, धीमे 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 हीट होता चला जाएगा और लास्ट टाइम पे सबसे ज़्यादा हीट होता है। तो वही टाइम आपका आ गया है कि क्लास अब आपके लिए खत्म होने वाली है। अब आपका जो एफर्ट 100% होना चाहिए, समझ रहे हैं? मेरे कहने का मतलब ये है कि ये टाइम ऐसा है कि आपके पास कोई एक्सक्यूज नहीं होना चाहिए। If the faculty is asking about the viva, you will be ready. अगर मैं कहूँ कार्बोहाइड्रेट मेटाबॉलिज्म का वाइवा लेना है तो आपको यहाँ से 15 मिनट में आप ले लीजिए वाइवा, कोई इशू नहीं है। इतनी प्रिपरेशन होनी चाहिए, ठीक है। अभी क्या करना है? अभी आपके पास कोई भी ऐसी स्कीम नहीं होनी चाहिए, कोई भी ऐसी पॉलिसी नहीं होनी चाहिए जो आप समझ ना पाओ। कहने का मतलब ये है कि आप किसी मतलब आप अपनी बुक उठाओ, अपने 10th ईयर क्वेश्चन पेपर लो, जो क्वेश्चन आए उनको प्रिपेयर करो, जो इम्पोर्टेंट है वो प्रिपेयर करो, और जो प्रिपेयर नहीं हो पा रहे हैं जस्ट लाइक जस्टिफिकेशन एंड क्लैरिफिकेशन ऑफ द क्वेश्चंस, जो 5 नंबर के जो क्वेश्चन आए थे वो इम्पोर्टेंट है। अगर वो आप नहीं कर पा रहे, लिख पा रहे हैं, तो आप हमसे पूछिए कि सर इस क्वेश्चन को कैसे अटेंड करना है, इसमें कितना कंटेंट लिखना है, इसमें क्या ऐड ऑन करना है। आप अगर क्वेश्चन बना के लगाएं तो दिखाइए आप, समझ रहे? The curiosity about the examination, about the marking, about your result develop in you. And there is no other method rather than hard work. हार्ड वर्क करोगे तो ही आगे बढ़ोगे, अगर हार्ड वर्क नहीं करोगे तो अच्छा रिजल्ट नहीं मिलेगा। क्लास में 3 टाइप के स्टूडेंट होते हैं। मेरिटियर्स जो अच्छा परफॉर्म करते हैं हमेशा मेरिट में आते हैं, एवरेज स्टूडेंट्स जो पढ़ते हैं पर अच्छा परफॉर्म नहीं कर पाते हैं, एंड लास्टली सिलेब्रिटीज जो थोड़ा सा एवरेज से भी लो एवरेज होते हैं। उनके लिए मैं कहना चाहूँगा बस आपको एक काम करना है, इस समय आपको अपनी बुक पकड़नी है, अपने सेल्फ नोट्स बनाने हैं और पढ़ना है। अभी वो टाइम गया कि आपको ये समझना है कि क्या करिकुलम में है, क्या आ सकता है, क्या नहीं आ सकता, बिकॉज यू हैव ओनली 3 मंथ्स। जनवरी आपको पता भी नहीं पड़ेगा कैसे निकल गया प्री यूनिवर्सिटी में एग्जाम देने में। दिस इज नॉट कंसर्न अबाउट द बायोकेमिस्ट्री, दिस इज फॉर ऑल द सब्जेक्ट्स। समझ में आ रहा है? सारे स्टूडेंट्स को ये दिमाग में डालनी है कि अपना टाइम बहुत इंपॉर्टेंट है, टाइम वेस्ट नहीं करना है। रूम पे जाओ, चाहे क्लास में 15 मिनट पहले आओ, चाहे क्लास में 2 घंटे पहले आओ, चाहे आप 8 बजे आप एलटी में जाके बैठ जाओ, वो 1 घंटे मॉर्निंग का अपने सिर्फ पढ़ने में लगा है, वही चीज़ आपको रिजल्ट में दिखाई देगी। अच्छा, कितना टाइम कैसे हुआ आप लोग? ब्रेकफास्ट हो गया? ब्रेकफास्ट तो जीओडी बीओडी परफॉर्म करेंगे आज हम। ओडी ब्लैंक की ओडी मैं आपको दूंगा, बाकी का टेस्ट आपको करना है। और कार्बोहाइड्रेट मेटाबॉलिज्म का पूरा पढ़ना है अच्छी तरीके से, और इवन वो भी पढ़ना है आपको क्या, ग्लूकोज रिलेटेड ऑल द हेल्थ क्वेरीज, किस केस में हाइपरग्लाइसीमिया होता है, किस केस में हाइपोग्लाइसीमिया होता है, what are the cause of that, and we also taking the bio of each pair, each practical you perform in the all of it come in the lab. Searching for a topic that I can see the PPT in my laptop, and this is the PPT which I make when I am doing my dissertations of teaching. Okay, so you have to learn more what how can I make the PPT and what is the name. You have to understand. I know most of the students know about the diabetes, that is a disease which is spread all over the world. Okay, and the main important sign of the diabetes is blue circle. It is presented, and whenever you see the World Diabetic Day, which is celebrated on the fixed date, there the sign to mention is the blue circle is also, which is a sign of diabetes. Okay. So most of the things you already know that diabetes is related with the metabolism, that something insulin play a role, either it is absent or it is insufficient present in the body to work over the metabolism. As I before many of the students, I will ask the question which is hypoglycemic hormone. Which one? कौन बताएगा? Insulin. Okay. Insulin is the hypoglycemic hormone. Now we also see the main metabolic pathway in which insulin play a role. Okay. So today we discuss in detail. I think all of you beneficial from this PPT. You can make the notes and see it now. The question is, what is diabetes? You already know the definitions of the diabetes, that diabetes mellitus is a group of disease characterized by high level of blood glucose resulting from defect in insulin production, insulin actions, or both. Understand? लिखो लिखोगे तो उसका भी प्रैक्टिस अच्छा होगा. फोटो मत खींचो. You already know the definition of the diabetes very clearly, because I will taught you many times in the class, also in the practical hours, that what is diabetes? It is a group of disease characterized by high level of blood glucose. Why it is called group of disease? Because it causes symptoms in the eye, it causes symptoms in the kidney, it causes also in the peripheral tissue of lower leg. Okay, that's why it is called group of disease characterized by high level of blood glucose resulting from defect in insulin. Thus ultimately we talk about the productions of the insulin from the pancreas. That is type 1 diabetic, insulin actions type 2, and the person who had both the conditions. Their production is less and the insulin which is already present in the body is not functioning well. Okay, the term diabetes mellitus describes a metabolic disorder of multiple etiology characterized by chronic hyperglycemia with disturbance of carbohydrate, fats and protein metabolism resulting from defect in insulin secretion, insulin actions and both. Multiple etiology means multiple cause. Here when you study the particular disease in a pathology, there is pathology and etiology. Etiology means the cause of the diseases. Okay? And the third one is, third important point, the effect of diabetes mellitus including long-term damage, dysfunction and failure of various organs. So already understand what I say. That means if you have person chronic hyperglycemia, that leads to damage of peripheral tissues, and depositions to form the cataract, okay, and dysfunctions and failure of various organs. ठीक है, now we change the slide. Next slide. Diabetes mellitus may present with characteristic symptoms such as thirst, polyuria, blurring of vision, and weight loss. So weight loss ultimately are after symptoms of type 1 diabetes and type 2 diabetes. In both of the diabetes, there is main important symptoms arises weight loss. And in type 2 diabetes, there is also a weight gain process. Okay? It is the most severe form, ketoacidosis or a non-ketotic hyperosmolar state may develop, leads to stoppers, coma, and in absence of effective treatment, death. Thus, ultimately, we talk about diabetic ketoacidosis. जो ऑलरेडी लोग ग्लूकोज मेटाबोलाइज नहीं हो पाएगा तो क्या होगा? वहाँ पे आपका फैट मेटाबॉलिज्म बढ़ेगा. जब फैट मेटाबॉलिज्म बढ़ेगा तो क्या बढ़ेगा? कीटोन बॉडीज बढ़ेगा. कीटोन बॉडीज 3 टाइप्स की होती है. एसीटोन, एसिडोएसिटेट, बीटा हाइड्रोक्सीबुटारेट. ओके? And beta hydroxybutyrate and acetoacetate is directly utilized by the brain when there is absence of glucose. Okay, when brain utilize the ketone bodies, they ultimately distribute disorientate their functions. Okay, they slurred speech, they are not able to speak, they are not able to identify, and ultimately, if we are not treating the patient, they ultimately go for finally in the coma state. Okay, so this is very severe state. Often symptoms are not severe, may be absent, and consequently hyperglycemia is sufficient to cause pathological and function changes, may be present for a long time before the diagnosis is made. Okay, means what I say in this point that diabetes is a regular disease in which there is no severe symptoms are arises. कोई ऐसी डिसीज नहीं है जिसमें कोई सीवियर सिम्टम्स अराइज होगा. पॉलीयूरिया क्या है? If we drink an alcohol, if we drink caffeine or coffee, then ultimately it increases the polyurination. Okay? In some of the disease conditions, some of the UTI can increase polyurination. Okay? So in both of the cases, what happens? We are not confirmed that the person having diabetes. So means that is the point, the person not having specific type of symptoms, it is totally absent. Consequently, hyperglycemia sufficient was pathological. And function changes which will be present for a long time before the diagnosis is made. कोई भी diagnosis बनाना सकता है. काफी टाइम हो जाता है कि उसको डायबिटीज कह देते हैं और काफी पैथोलॉजिकल चेंजेस उस टाइम पे होते हैं. Now we see the diabetes long-term effect. If you have any queries regarding from any point, you will ask me. The long-term effect of diabetes mellitus includes progressive development of the specific complication of retinopathy with potential blindness, nephropathy that lead to renal failure, and neuropathy which risk of foot ulcers, amputations. Right? Foot ulcer, let's know that something is something injuries may happen in the foot and they are not capable to bounce. So it may cause ulceration. So there is the term amputation used by what the meaning of amputation? Yes, amputate करना, किसी चीज को काटना. मतलब ये कह रहे हैं कि अगर हम we are not able to diagnose a disease, we are left the patient for the chronic complication that ultimately develop the foot ulcer, and finally the treatment is amputation of this ulcer. Okay. Care of joints, feature of autonomic dysfunction, including sexual dysfunctions. So all the ability of it is also imbalance of sexual hormones. Okay. Due to this ultimately causes dysfunction of several important autonomic dysfunctions. Now people with diabetes are at increased risk of cardiovascular, peripheral vascular, and cerebrovascular disease. This is what we talk about. We talk about the micro and macrovascular complications. Understand? Charcot joint is something related with the bones, I'm not clear about this one, I will tell you. So people with diabetes are at increased risk of cardiovascular disease, ultimately leads to what? Myocardial infarction, having a chances of cardiac failure, peripheral vascular, that means the small blood vessel which is present in the skin, peripheral surface. Okay, समझने की कोशिश करो, जो ऊपरी स्किन पे जो भी blood vessels होती है ना, वहाँ पे क्या होता है, glycation हो जाता है, glycosylation of the protein, which I already told you. The small arteries become hardening. Why it is hard? The protein which is present in the blood vessels going to attach with the glucose molecules, and there is regularly deposition of the glucose, and these protein glycation processes regularly occur, and these mean hardening of the blood vessels of the peripheral tissues, and ultimately cause what? Ultimately cause peripheral vascularization. What is vascularization? What is neovascularization?
New function of new muscular
New blood vessels. Okay. And cerebrovascular disease. It is ultimately related with disease with the blood vessels which is present in cerebral, peripheral tissue, cardiovascular. Okay. Now we see the problem. We'll pick other related. Now the problem is retinopathy, common cause of blindness in people working age. Nephropathy. What the meaning of 20% of all ESRD? ESRD means end-stage renal disease. End-stage renal disease. Erectile dysfunctions, macrovascular, 2 to 4x increased risk of CVD, cardiovascular disease, 75% have hypertension. Foot problem, that is amputation, knee amputation. Amputation you already know. What is the meaning of that? It is a treatment of foot ulcer. Amputation. Ampute करना है. अगर है ना क्या होगा? Ampute करना है. Ampute means there is a treatment, surgical treatment of the foot ulcer. All understood? Now this is all about pathophysiology of the diabetes. Now we are going for biochemical expectation. Why it is mainly caused? Type 1 diabetes was previously called IDDM and juvenile onset diabetes. Type 1 diabetes developed when the body immune system destroyed pancreas and beta cells. इसका एक ले लो चाहिए ये तो पॉइंट नोट कर लो सारे पॉइंट हाँ pancreatic beta cells that only cells the body that make the hormone insulin that regulate blood glucose. What I talk about it is alpha cells or beta cells. It is beta cells of Langerhans which are ultimately destroyed by autoimmune disease, autoimmune disorders. And after that, when the cells are destroyed, they are not able to produce insulin. Okay? And but alpha cells are regularly produce which hormone? Glucagon. Glucagon is called hyperglycemic hormone. So it ultimately causes hyperglycemic state. Okay? Now these forms of diabetes usually strikes children and young adults. Although disease onset can occur at any age. Means generally the type 1 subject you will find in this population we have in generally the children. Okay. So here the disease only in children. Type 1 diabetes may account for 5% to 10% of all diagnosed case of diabetes. That is what we call disease incidence. There are the two terms are generally used when you write the answer: incident and prevalence. What is the meaning of incident? The occurrence rate of the disease in the population. How many populations are affected by the disease or incidence, and prevalence is how the disease is spread all over the population. So 5 to 10% of all diagnosed cases of the diabetes. Understand? That is called incidence rate or prevalence rate. Risk factor of type 1 diabetes may include autoimmune, genetic or environmental factors. So these all are include to generate type 1 disease, type 1 diabetes. Okay? Now type 2 diabetes, that is NIDDM, which is generally spread over 90 to 95% of diagnosed cases of diabetes. It is begins as insulin resistance. What is the meaning of insulin resistance?
Receptor is not potent for action. So even with insulin,
Even after the process of insulin or motivation, black two is
the glucose level
And
is always
insulin can play a role for entry of the glucose inside the cell. That glut 1 to 3 is dependent on the insulin. It's right or wrong. Glut is energy dependent process or yes or no?
That is not mentioned.
This is passive. Okay. But some of the factor which is depends on the insulin. That is insulin resistance means the cells are not respond to the insulin to enter inside the cells. If the insulin is not entered, they ultimately not causes the lysis of the glucose molecules. Okay? And generally insulin resistance is developed in the person who have larger BMI. What is BMI? Body mass index. Okay. Body mass index is generally an index which I will teach you in the nutrition topic. That is the mass index when the body skin size appropriate and increase in appropriate ratio. Okay. And second thing, insulin resistance developed in gestation women, those who are pregnant. Okay. That's why it causes type 1 gestation diabetes. A disorder which said do not use insulin properly, as the need of insulin rises, the pancreas basically loses their ability to produce insulin. Type 2 diabetes is associated with the older age, obesity, family, history of the diabetes, history of the gestation diabetes, impaired glucose metabolism, physical activity, and race and ethnicity. These all are the causes.
Sir, वो gestational diabetes are
This is recessional means some of the persons, like I will tell you when I will teach you iron metabolism, there is 1 to drive. There is hepatochromatosis. But एक पर्टिकुलर एरिया में किसी एक पर्टिकुलर पिटूस में डायबिटीज होना, that is called recession. Recession you know? हेमाग्लोबिन पढ़ा है कि नहीं पढ़ा तुमने? हाँ, उन्होंने यही बताया था. The recession hemoglobin, what is that? It is separation of a society on the basis of their specific character. Understand? So some of the people who are prone to develop diabetes due to their particular age, it is called race, ethnicity. In the second point, African Americans, Hispanic, Latin Americans, Indians, and some Asian American native Hawaiians and other specific islanders are a particular high risk of type 2 diabetes. They mention here race. यहाँ पे सभी क्लियर हुआ? सारी चीजें डिटेल में कोई चीज नहीं. Type 2 diabetes is increasingly being diagnosed in children and adolescents. Now some cases of insulin resistance. ये आप नोट कर लो, ये आप सब लोग बहुत इम्पोर्टेंट है. नोट करना नोट करो, कोई ना बोलो. Obesity, overweight, especially excess visceral adiposity. When the person having more weight due to consumption of food and less exercise. Okay, less exercise, lastly less physical work, then sedentary lifestyles. So all these are the cause of insulin resistance. We have not talked about the diabetes. We have talked about insulin resistance. Understand? Excess glucocorticoid hormone, Cushing syndrome. And last discussion today in the practical session. How the Cushing syndrome induces diabetes.
it's a high level of cortisol. That's why
Yes.
glucose is increasing.
Yes. Adenine cortisols excess. This is cellular glucose metabolism is regulated. Excess growth hormone, acromegaly, pregnancy, gestation diabetes, polycystic ovary disease, lipodystrophy, autoantibodies to the insulin receptors, mutations of insulin receptors, mutations of the paroxysm polyphenol activator receptor gamma. Alpha. Mutations that cause genetic obesity, hemoglobinopathies, that is called bronch diabetes. These all are the causes of insulin resistance. Now gestation diabetes. Gestation diabetes, a form of glucose intolerance that is diagnosed in some women during pregnancy, and it may more frequently among the African American people And lacking of incomes glucose, it is also more common among obese women and women with a family history of diabetes. So all are the prone to chances to have diabetes. Means the women who are already obese and get pregnant, they have high risk of type 2 diabetes because it causes what? Insulin resistance to the resistance of the cell towards insulin. During pregnancy, gestational diabetes require treatment to normalize maternal blood glucose level to avoid complication in the infants. After pregnancy, 5 to 10% of women with gestational diabetes are found to have type 2 diabetes. There will be a chances, but it is only a conception. It is not authorized and it is not particular statement that if a woman having diabetes, they may have the infants may have the diabetes. This is only a conception. Okay, women who have gestational diabetes have 20% to 50% chance of developing diabetes in the next 5 to 10 years. Yeah, if the women are pregnant, they develop diabetes and they will curable. But after some time, there will be chances to become more diabetic. Now, insulin, we get in detail today already well, and you know well. Insulin is the protein hormone secreted by beta cells of islets of Langerhans of pancreas. Insulin is an important anabolic hormone which acts on variety of tissues. Major target tissues are muscles, liver, adipose tissues, and heart. Biosynthesis, synthesis of pre-proinsulin, that is from first conversion to pre-pro, conversion to proinsulin to insulin. Understand? So what is here? Here is detachment of the amino acid. What is the insulin? Insulin is a good example of primary structure of protein. That is amino acid are which are linked together by peptide bonds. Okay? So pre-proinsulin is synthesized in polysomes attached to the membrane of rough endoplasmic reticulum in the beta cells of Langerhans. After synthesis, it transferred to the lumen of rough endoplasmic reticulum cisternae. And pre-proinsulin containing small vesicle release endoplasmic reticulum and fuses with cisternae of Golgi apparatus. In the Golgi cisternae, proinsulin is acted upon the trypsin-like protease which handles the peptide chain at two sides. So already you know that is not to be discussed. That is the formation of pre-proinsulin to insulin in insulin. ऐसा डायग्राम बनाना आना चाहिए तब ना बोलते
ये सब याद रखना पड़ेगा महीने से
क्यों बड़ा स्टेप क्या है ग्लाइसिमिक लेवल पूरा यूजिंग 16 मिलियन याद कर लो उसको नहीं याद हो रहा था उसको जैसे वाला अच्छा हो सकता which point is present between 16 and 16 ऐसा how many molecules are there 50 already mentioned in the slide 51 have you seen it 51 two chains linked by diagonal bond molecular weight is 5800 who can discover anything by which technique insulin is synthesized? Artificial insulin. Synthesized by which technique? Which technique? That is RDT, recombinant DNA technology. By the use of RDT, there is insulin synthesized. Now insulin receptors. Insulin receptors synthesized as a single chain polypeptide core receptors at the rough endoplasmic reticulum. And glycoside in Golgi elements. The half-life of insulin receptor is 6 to 12 hours. And high glucose levels decrease the number of insulin receptors on targeted cell membrane because it reduces insulin sensitivity on target tissue. That is important point. Means if there is hyperglycemia, there is regular level of the blood glucose is increases. This ultimately reduce the number of insulin receptors. Okay. These are generally attached to the cell membrane, and if these are less, they increase the sensitivity on target tissues. Ultimately, insulin is not entered in the cell. Okay. Now mechanism of action, that is important. Insulin bind to a specific plasma membrane receptor present on a target tissue, on adipose tissues and muscles. Especially three kind of mechanism of single transaction. Mechanism single transaction you आपको गए single transaction टॉपिक नहीं हुआ एंडोक्राइन हो गया हाँ उसी में single transaction. These are the change of the signals by the activity of hormones. Okay. So special three kind of mechanism of single transaction, mechanism of insulin action, a conformation changes of the receptor. These receptor cross-links and form microaggregates. These more single transated second messenger. And you know what is the second meaning of second cyclic AMP. Role of cyclic AMP, the insulin receptor binding activated one nitrate cyclic and cyclic GMP dependent protein kinase. These may phosphorylate some enzymes to modulate their activity. So basically, what is we are talking about? There are two types of state: dephosphorylation and phosphorylation. Okay, insulin induces phosphorylation state, and due to this phosphorylation state, some of the enzyme is dependent on this state. Which enzyme depend on phosphorylation state? Glucokinase, phosphorylation state. Understand? So most of the enzymes are depend on these both of the state for dephosphorylation and phosphorylation. Dephosphorylation is removal of phosphate to form the substrate. Understand? Phosphorylation is phosphorylation. Now these are the mechanisms. These are something more in detail. So all of you just understand that some of the receptor which is present in the plasma membrane and insulin will present these causes substance transactions, and due to this the blood flow responsible for entry of the glucose inside the cell, and this causes the conformation changes of this substance, and due to this molecule enter inside the cell, and further on they go for some specific cycle that is called glycolysis. Have you seen the glycolysis? Hydrokinase, glucose phosphate metabolysis process. Now, all these are what? These are the receptors and some integrating protein. बहुत डिटेल हो गया अब इतना कुछ में बताना पड़ेगा ठीक है अभी क्या रोल ऑफ प्रोटीन फॉस्फेटेज इंसुलिन रिएक्ट्स टू द प्रोटीन फॉस्फेटेज which can not dephosphorylate certain key enzymes tyrosine activity these are what tyrosine activity is क्या करता है tyrosine kinase induce phosphorylation phenolic OH to tyrosine residue of specific protein leading to change in the enzyme activity. These all are changed due to the insulin. Now, the role of gene expression in the now you understand what is the effect of insulin on overall metabolism. ठीक इस स्लाइड को कॉपी करना और ये सारी स्लाइड पढ़ना सारे चेंज ये हो जाएंगे Action on carbohydrate metabolism. Increase glucose uptake from food. Insulin increase glucose uptake from extracellular fluid by various tissues, by muscles and adipose tissues. Ultimately, so why it is called hypoglycemic? It takes the glucose from the blood. So ultimately, what is that? They reduce the level of the glucose from the normal level. Where the normal level of the glucose recommends show up to 140 per day. Okay. If the person has pre-diabetic, it is 150 to 160. This can uptake by the insulin. And if the glucose molecule is regularly uptake by the insulin, they can degrade the glucose molecules and they regulate the homeostatic level of the glucose metabolism. Understand? In adipose tissues and other extrahepatic tissues, insulin stimulates translocation of glucose transporter from their intracellular pool to polycystine to the plasma membrane, where they can participate as a carrier in transportation of D-glucose and D-galactose across the membrane. So all of you write this point. सब लोग लिख लो और इस point को ध्यान से पढ़ लो. जब भी अभी आता है ये क्वेश्चन उसको अपनी कॉपी में लिखना, ठीक है? I am not writing these sentences directly from any internet and any other sources. I used to read the books, different books. Then I will write the sentence. Understand? In adipose tissue and probably other extrahepatic tissues, insulin distributed, translocation of glucose transported, transported from their intercellular pools in Golgi system to the plasma membrane where they participate as a carrier in transportation of D-glucose and D-galactose across the membrane. In hepatocytes, insulin increase hepatic uptake of glucose. Freely permeate to the liver cells, it increase the synthesis of enzyme glucokinase. So I expect the one question answer from all of you. What is the difference between glucokinase and hexokinase? अरे कोई कहानी ऐसा खराब है सब नहीं कर चलो करेक्ट करो
Glucokinase can phosphorylate from the glucose and from glucose 6 and hexokinase can phosphorylate any 6 carbon compound, 6 carbon
Basically, the difference is that here only one, the activation of hexokinase is less and the activation energy of glucokinase is more. So when we take glucose inside the cell, firstly hexokinase is activated because there is less activity. ये दो इंडिया में इसका एक्टिवेशन एनर्जी कम है, ठीक है, और इसका एनर्जी कम है, अगर ग्लूकोज मॉलिक्यूल लिया कौन ऐड करेगा? hexokinase ऐड करेगा. Increased glycolysis, increased utilization of glucose for providing energy, which takes place in muscle, liver, and many other tissues due to increase of key enzymes, PFK and also pyruvate kinase. You already know all this because in the whole year you studied glycolysis. Increased conversion of pyruvate kinase to acetyl-CoA. Pyruvate kinase to acetyl-CoA. Increased insulin increased aerobic oxidation, decarboxylation of pyruvate to acetyl-CoA because it causes dephosphorylation of PDH, pyruvate dehydrogenase complex. So as I told you that some of the enzymes are dependent on dephosphorylation state and some of the enzymes are dependent on phosphorylation state. And both the states are maintained by insulin hormone. Okay? Stimulate glycogenesis. What is glycogenesis?
Degradation of glycolysis.
What is glycogenesis?
What is glycogenesis?
Yes.
So the formation of glycogen.
Yes. Formation of glycogen from glucose. Decrease gluconeogenesis, decrease glycogenolysis, increase HFP. ये point आपको if somebody is asked a question to you how insulin regulates blood glucose, so you directly say this all the points. It stimulates glycogenesis, decrease gluconeogenesis, decrease glycogenolysis, and increase HHP. The net effect is lowering the blood glucose level and increased glycogen storage. Now, action on lipid metabolism. फोटो ले लेते हैं इसका, सब इसके मोबाइल में फोटो ले लेते हैं. बहुत इम्पोर्टेंट साइड है. Decrease glycolysis. Glycolysis is what? What is the meaning of glycolysis?
Sir, the breakdown of lipids.
Yes. Breakdown of lipids. Glycolysis due to activation of phosphoprotein phosphates, which is dephosphorylated the triethylglycerol lipase and converted to inactive form. So what I definitely mean all of you understand, insulin activate phosphodiesterase which degrade cyclic AMP and prevent phosphorylation and reactivation of TG lipase. So ultimately there is again it is talk about the single transactions. Okay, the phosphorylation and dephosphorylation state is maintained by the insulin. Increased fatty acid synthesis, insulin increased extra metabolic de novo synthesis of making available synthesis substrate cyclic OA and also increased activity of acetyl CoA carboxylase. Increased synthesis of TG and decreased metabolism. So if you make the answer of these questions which asked in the exam, you don't write it all these theories. You will write the definition. Increased glycolysis, increased synthesis, increased synthesis of TG, decreased ketogenesis. Okay? So what is the net effect of TG? Net effects are lowering free fatty acid level and increased TG storage. Okay? Now what is the effect on protein? Net effect of insulin promotes protein synthesis. Okay? How it is? Insulin increase amino acid uptake by the tissue by enhancing the rate of synthesis membrane transporter for amino acids. How it is increased? Insulin increase protein synthesis by providing more amino acid in cells. In the more amino acid in cells, that is ultimately we talk about central dogma, molecular biology section. Effective gene transcription and effective translation of ribosomal level, regulation of ribosomal level in two ways: increase synthesis of polyamines, insulin modulate ribosomal activity of phosphorylation. So net effect ultimately is what? On insulin promotes protein synthesis, and there is some also effect on mineral metabolism, decrease the concentration of potassium and mineral phosphorus, and glycolysis and phosphorylation of glucose. तो ये बहुत बड़ा है ना, बस ध्यान से देखो। ऐसा चार्ट बनाना आना चाहिए आपको। बना पाओगे? ऐसा बना पाओगे चार्ट एग्जाम में ना? ये बनाना आना चाहिए। Gastrointestinal hormone, amino acid, pancreas, insulin is released, and this insulin causes effect over our body, which is mentioned here. Protein synthesis, glucose uptake, glycogen synthesis, glucose uptake, insulin metabolism. So here, in every each of the tissue, what is the net effect of insulin is clearly shown by this figure. समझ में आया ये? डायग्राम पूरा समझ में आ रहा है? Now, entry of glucose into the cell, it is dependent process, blood 1, blood 2, so all these other transporters are not कितने ग्लैंड होते हैं? How many types of glands? कितने ऊपर दिया? Blood, how many types of blood transporters? Glucose transporters, four transporters. These are up to 5, 4, 6, 7. But here you mentioned there are mainly 1 to 12 number present in human genome at different body organ like grade 3 for brain, neural, grade 6 for spleen, leukocytes, grade 2, 8 for testes, astrocytes, grade 2, 12 for skeletal and muscles, adipose tissue and small intestine. These all are what? These are the blood transporters. Okay, glucose blood transporters, and through the glycolysis goes to mitochondria for glycolysis, next one transportation for the production of ADP. Okay, ADP is produced, and these ADP are ultimately phosphorus. This ADP is converted into ADP, and these phosphorus molecules go into next transporter molecule for their activities. Okay. And between the glycolysis cycle, the cytokines both the glucose, the cell is inverse molecule. Same process here. Insulin uptake, how it is maintained. Glucose by take, glucose is phosphate, ATP, they go to channels, depolarization, polarization, chelation channel opens, and this chelation promotes the insulin synthesis. And these all are the factor and condition which can decrease insulin secretion. Insulin increase secretion during blood glucose, intake of blood glucose, free fatty acid, amino acid, GIT hormones, glucagon, growth hormones, parasympathetic stimulations, beta adrenergic stimulation, insulin resistance, sulfonylurea sugar. What is leptin? Leptin is basically a hormone. कुछ लोग कहते हैं ना कि जैसे थोड़ा खाना खाते हुए रेस्ट कर जाते हैं. The leptin activity is high. Okay, it is increase the fat storage, leptin. So what is that? This is the general difference. Now management of diabetes mellitus. You already know how to manage.
GBS side.
How do you manage? Generally, we regular exercise, dietary restricted diet, regular exercise, restricted diet, नीचे और क्या है? सही सदा. These are oral anti-diabetic agents, flavonoids, sulfonylureas, non-sulfonylureas, alpha-glycosides inhibitors. TJs सब नोट कर लो, ठीक ले लो, अच्छा. What are the action of this oral agonist medication? Sulfonylureas क्या करता है basically आपका? Increase insulin secretions. Maglin phenylates insulin secretion by mammary cells. TJs glucose uptake by skeletal muscles. Alpha glucosides inhibitors inhibit carbohydrate absorption in the small intestine. You have to write it and you have to just understand the mechanism of action. And these are the brand names. I think it is not necessary today for all of you. But tomorrow when you are become a physician and regular clinician, then it is some things are mandatory that you already know the name of practice. Metformin, common name है metformin. That is separate to metformin चल रही है. कुछ लोग रेड पिल में भी देते हैं, रोज़िग्रेन में भी देते हैं, these are also drugs. Insulin therapy आपको acute illness, surgery, sterile emergencies, pregnancy, breastfeeding, or severe metabolic decompensation. In the case of leakage, non-ketogenic lactic acidosis, saturation. For three types of insulin, there are something insulin taken how many range at what time. It is not necessary to all of you. कब लेना है हमारा टाइम मिलेगा? आयुर्वेद में भी है कुछ. आयुर्वेद का ट्रीटमेंट ज़्यादा थोड़ा चल रहा है. Actually, इसके साइड इफेक्ट होते हैं. But if you want to cure the disease, you have to take the medicine. That is compulsory. There is no secondary option for that. Okay. Now something, there are some panchakarma herbs generally used. There is diet modifications. आपको कौन सी डाइट लेनी, फाइबरस डाइट लेनी चाहिए, आपको मेथी दाना खाना चाहिए, ठीक है. All of you take to reduce the post-prandial level of blood sugar. Fasting blood sugar आपका जो भी है, खाना खाने के बाद अगर आपका blood sugar बढ़ रहा है तो उसके लिए क्या है high fibrous titin some of the Greek holy vessel universal strain ये सब वो है क्या कहते हैं अभी सब इसका रिसर्च चल रहा है गूगल और अदर रिसर्च but some of the foods you will take regularly okay yes but as it has foods self care is important regular exercise patient should be educated to practice self care समझ रहा है थोड़ा डायग्नोसिस सेक्शन में पीपीटी दिया वो पढ़ेगा वो पढ़ेगा उसमें क्या आपने कई क्वेश्चन करने हैं अभी ऐसा प्रेजेंटेशन हमने दिया था उस समय पे जब हमने स्टार्ट किया था यूनिवर्सिटी इतना बड़ा प्रेजेंटेशन बनाना ये सारा कवर कर रहे हैं ना डायबिटीज के लिए